Hello and welcome to webinar series. Shanti here the side, and today's a very interesting topic for discussion is all about on resistant hypertension, and we'll a little understand through a case-based learning from Dr. Kashyap. Yes, because this group of patients face a much higher risk of cardiovascular event, stroke, and end stage of renal disease, as we all know, and fatal death compared to those with controlled hypertension. So for this discussion, I now welcome Dr. Kashyap Vyasji, who is our senior consultant, interventional cardiologist from Yashoda Hospitals, Somajigoda unit. I welcome you, Dr. Kashyapji. We are honored to have you with us today.
Yeah, good afternoon, everyone. Thank you for having me over here. And please do continue, Miss.
Thank you. And now I request all the speakers to introduce. Yes, Lavanya, over to you.
Good afternoon, Chair. Good afternoon, ma'am, panel members, and all the participants over here. I'm glad to be a part of this scientific webinar on resistant hypertension and case-based learning. I would like to thank Shanti ma'am also for giving me this opportunity to learn here. So myself, Ms. K. Lavanya, Assistant Professor from Navodaya College of Nursing. Over to you, ma'am.
Thank you, Lavanya, to you. And I like to thank Emmanuel also, the principal of Navodaya College of Nursing, since he supports and participates. He also participated multiple times.
Yes,
So
ma'am.
thanks to Raichur State. Yes, over to you, Nilima.
Thank you, ma'am. Thank you, ma'am.
Good afternoon, sir, and good afternoon, ma'am. Good afternoon, the panel members and all the participants. Myself, Neelima. I'm very grateful to Shanti ma'am for choosing me for this and webinar. It's a great opportunity to learn from the sir and the Shanti ma'am also. Thank you once again, ma'am, and over to you, ma'am.
And I would like to extend my thank to Century Renova Group of Hospitals as well to Ms. Sunita for extending her support in terms of nominating the speakers as well. Yes. Yes. Over to you, Halina.
Good afternoon, all. Thank you for having me here. Myself, I am Ellen Raju, and I'm pursuing BSc Nursing fourth year from Yashoda Lakshmi College of Nursing. So, first of all, I would like to thank Shanti ma'am and sir and all the panel members for giving this auspicious opportunity. Thank you.
Yes, we must extend our thanks to Siddhama Madam, who is the principal from Lakshmi College of Nursing, Gaudavalli, one of our great institute. And thanks to your faculty, and thanks to Ms. Sanita, who is here accompanying you. Yes, going forward now, this is the very, the important slide, and we wish to understand here from Dr. Kashyap, like what are the incidents currently happening, and regardless of this disease, and in terms of the treating the cardiovascular health. Yes, sir, over to you.
Hi. So just want to have a brief introduction. See, resistant hypertension is something when you say that you're taking more than 3 drugs and still the BP is not achieved the targeted. So whenever, if you're having more than 3 medications, that should include diuretics, thiazide-like diuretics, along with calcium channel blockers, ACE or ERB inhibitors. And if the still is BP persistently high, if it is not reaching the target of 130 and 80, then we should label it as a resistant hypertension. So just go to the first slide, madam. Now, as you asked me regarding the incident and prevalence, see, India is known, I just talk about India because
Yes.
India is known as the hypertensive capital of the world. And most of the patients are having unknown hypertensive and they are diagnosed in the very late stages. And most of the patients are not willing to accept that they are hypertensive. Because of the delay on this, most of the patients, almost 1 in 5 hypertensive patient is having resistant hypertension. And once you have developed a resistant hypertension, it will take a long time to control that blood pressure. And it has already damaged the end organs like kidneys, heart, and sometimes even the brain.
Yes.
So that's why it is important to know that not all patients immediately come with resistant hypertension, especially primary hypertensive patient. Yes, next slide. Yeah, this
Yeah. So let us see what we have in the
Sir,
rest of the session, Lavanya, as the sir has clearly defined this, and
yes,
so the slide is over to you for your learning
ma'am.
point from Dr. Kashyap. Yes.
Yeah, this slide I have already presented, like
Yeah,
132.
Yes, sir.
Lavanya has
Sir, as you
really,
rightly said, yeah,
yes,
one some doubt.
Lavanya.
I want to gain some insight in here, sir. Sir,
Yeah, please.
sir, would like to know what is the scientific rationale behind considering only three specific classifications of antihypertensive drugs in
Mm-hmm.
defining resistant hypertension, sir.
Mm-hmm.
So why not, like, we have so many classifications of antihypertensive drugs, but here we are going only for diuretics, ACE inhibitors, or ARBs, or calcium channel blockers. So why
Yeah.
not like beta blockers or alpha blockers?
No, beta and alpha blockers are not the first line of management of hypertension. These are
Yes.
the first line of management of hypertension. So that is the reason we first introduce the three medications, followed by which, if it is still uncontrolled, we'll have a spironolactone, then we'll have a beta blocker.
Yes.
Beta blocker is on the fifth step, not on the first, second,
Okay.
third, or fourth.
Okay.
So,
Thank you, sir.
sir,
Thank you for that.
yes. So my query is initially when the client visits to you
Mhm.
and it is confirmed that client has the resistant hypertension, right from that initial stage they got to have this medications, right, sir?
No, we first we if he's a new hypertensive patient, we don't know whether he's a resistant hypertension.
Yes.
We have to
Yes.
initiate him on the first line of treatment of hypertension, followed by regular follow-ups. If the BP is not controlled, then we can label it as a resistant hypertension, not on the first visit.
Yeah, very great insight you have provided. Yes. So now, likewise, we will the speakers would like to ask their queries to you. Yes. Over to you, Nilima.
Yes, sir. Sir, I would like to know regarding this,
Sorry,
other
you're
than
not,
this thing, sir, is there any other, sir,
you're
can you
not,
hear me, sir?
no, you're not audible, madam.
Uh,
Yeah, somewhere you
Hello?
can just be stable in one place and then yeah.
May I
Yes,
audible, ma'am?
Nilima.
Yeah. Uh,
Now you're
Sir,
Yes,
audible.
I would
yes.
like to know, there are several checkpoints to include, like ECG, echocardiogram, and other blood tests. Is there any other ways to confirm that patient is hypertensive, sir? Over to you, sir.
Initial generally, Rao, what is the recommendation is any
Yes.
patient coming with a higher BP, example, if a patient comes of a 40, 45 years old with a blood pressure of 160 by 100, then he is most likely a hypertensive patient. But if he is in between the gray region, between 130 to 150, so for that, if we want to avoid a white collar hypertension treatment, we should do a 24 hours ambulatory blood pressure monitoring, as the slide is suggestive of. So it's
Yes.
better you do a 24 hours ambulatory blood pressure monitoring. And also in this urine examination is important. Since if the patient is leaking protein, so you can suspect that the patient is already a hypertensive patient, not on medical management.
Okay, sir.
Yes.
Thank you,
So
sir.
yes, Alina. Yeah.
Sir, from the previous slide, we have came to know that apart from the clinical history, we can study from the physical examination about ambulatory blood pressure monitoring. So this ambulatory blood pressure monitoring is about wearing a portable automated device for 24 hours to track the BP of a particular patient. So is it possible that for a working patient or like any for a patient to wear this 24 hours like for ambulatory blood pressure monitoring, it may not be possible, right? So over to you, sir.
I don't know because I think in a week, one day off is for all the persons in the world.
Yeah.
So
Yes.
during the week off, he can have it, or during Sunday he can have it. And if he's not a laborer, he doesn't have a lot of job like IT professional, they can use it easily.
Okay, sir. Okay, sir.
So you mean to say only one day recording throughout
Yes,
24 hours is important to just
yes. First,
come to
24
you?
hours is
Yeah.
sufficient.
Okay, okay. And Dr. Kashyap, I would like to understand also, is this devices, do they purchase from outside or like
No,
how?
no. Actually, it is very reasonable price. It is reason between 500 to 2000 rupees only.
Yes.
So it is
Okay,
not that
yeah.
expensive.
Yes, yes. So very great to understand. And I think they are asked to document activities, medication time, sleep, wake period, etc.
So
Maybe
that
they,
everything will be recorded. So
yes,
it is a good
yes.
way of
Tracking the BPS.
yes.
Yeah. Very interesting. And yes, going forward, I wish to understand because when I was going through this content, and I was surprising to understand that, white coat syndrome terminology also exists. So does
Yes.
it happen with you or any time or your patient had this similar patient of experience? Yes, sir.
I am not a scary doctor, madam. So I have very less patients who have this syndrome. And
Yeah.
generally, even having a doubt, so I do a 24 hours ambulatory blood pressure monitoring. And if
Yes.
it's still high, then I will ask them to go for BP medication. But not, I faced a very less, I think hardly one or two patients in my career.
But does this happens in the real lifetime? Because
Yes, yes,
everywhere it
yes.
is mentioned,
Yes,
even in European Society of Cardiology in the ACLS protocol, all
yes.
that.
It is
Yes,
quite common.
quite common. Yes,
So you should
and
be friendly
yes,
with the patient.
yes, yes. Yeah. So let us also rule the causes. Yes, Lavanya.
Yes, please.
Sir, actually, as we all know that there are many causes of resistant hypertension like excess salt, weight gain, liquidized herbs, cigarette smoking, lack of exercise, non-compliance to the antihypertensive medications and fallouts.
Mhm.
So I would like to know what are the common secondary causes that should be screened for in resistant hypertension, sir.
See, now they have a very specific guidelines for screening of resistant hypertension. Especially, I think the brief detail has been explained taking urine, RFT, ECG,
Yes,
echo,
yes.
and in addition, you should also test for what we say Cohen syndrome.
Yeah.
Primary
Okay.
aldosteronism is also there.
Hyperaldosteronism.
Yes.
Yes.
And also, we have to do investigation regarding any renal artery stenosis is there or not. That itself will cause resistant hypertension, along with obstructive
Yes.
sleep apnea. All this causes resistant hypertension.
Yes.
Sir,
Yes.
I would even like to know what are the most common drugs which lead to increase in BP.
Sorry, I'm not able to understand. Can you repeat the
Sir,
question?
like, yes, sir, sure. So can you just give me an insight, like, what are the drugs or like most commonly drugs which will lead for high blood pressure?
See, it is not that common. See, what we read in the books that this drugs causing high BP is very few
Yes,
drugs.
sir.
Most likely it is seen in
Yes,
antipsychotic
sir.
drugs. But generally, drugs has a different
Okay.
parameter. The people who are on ecstasy or
Yes.
doing
Yes, yes, sir.
cocaine
Okay.
regularly, and all this will
Okay.
cause high BP. But especially few drugs are only there, but that is not used in a common practice. It is
Yes.
very typical in a very high neurological advances and psychiatric drugs.
Yes. That is the
Yes.
reason we all are
Okay.
learning
Thank you,
from you
sir.
No,
because
actually, for
Yes, sir.
drug causing high BP, I generally do pharmacogenomic testing. So we'll come to know which drugs will cause the BP for that patient.
so yes, so very
Okay. Thank you, sir.
yeah. Going forward, yeah, Nilima.
Sir, in RHTN, there are more common in the above age of 75 years.
Yes.
Obese patients and diabetic chronic kidney patients are the heart disease patients. Is
Mm-hmm.
there any other age group or the high risk patients um, regarding this? I mean, in the RHTN, sir?
No, no, I think it is covered in depth regarding obese, hypertensive, and whatever is given here. I think this is sufficient to say that they are the more prone for resistant hypertension. Especially CKD patients are more prone for it.
More prone.
And one more
Yes.
thing, I think transplant patients also have a more prone for resistant hypertension.
Yes. Yes. Yes.
Yes. Sir, I would like to add here.
Mhm.
Uh, is there like any gender related thing, sir, for the resistant hypertension?
No, madam, it isn't. After a certain age now, it doesn't matter. It's mostly males is to females, almost in the same ratio.
Same ratio. Yes. Yes.
Thank you, sir.
Great. Actually, we were very, excited to see which gender is mostly affected, and then that's how she bound to ask this. Yes.
Yes.
And
Uh,
yes. Yeah, going forward. Yes, Lavanya. Or Alina. Yes, Alina, this is your
So,
turn.
as per the
Agree.
previous slide, in case of the kidney involvement, for 24 hours urine for aldosterone, sodium, and albumin. So, coming to renal denervation. So, when we do consider that renal denervation as a in resistant hypertension, sir,
Yeah, I'll
or
tell
is
you.
it long effective for all the patients?
See, the renal denervation is still a newer intervention. It's
Yes.
Yes,
hardly been studied for 10 to 15 years.
yes, sir.
Right now, I think in Yashoda High Tech City, Dr. Rajshekar sir is doing good numbers of renal denervation. And when we spoke in length regarding it, it is reducing good. It's reducing around 5 to 15 of systolic blood pressure and between 4 to 14 of diastolic blood pressure. So it has a good progress.
Yes, sir.
You generally use this when everything, other drugs are not being able to control.
Yes, sir.
And post procedure, maybe say after a week or two, does the drug regimen decreases? Like patient have to consume not 3 to 4,
No,
maybe
no, no,
two,
no.
or
Still, they have to consume that.
it has to be continued. Yes,
So, sir,
yes.
I would like to add one more doubt like how much of percentage that we can reduce our BP while we are using this renal denervation?
Yeah, just now I told you, na, it's between 5 to 15 systolic blood pressure
Okay,
Yeah.
okay. Thank
and 2 to 12 maximum diastolic blood pressure.
Okay,
Yes.
thank you, sir.
But that's a very great and good amount,
It's a good amount
I
of,
think.
it'll affect, it'll help in improving the lifestyle also.
Yes. And here we all are very excited and to learn as you said about the case which is treated
Yes.
by you.
Yes.
And yes, over to you for we just want to understand a 70-year-old male
I
story.
think this is same, this case I did 1 year back. It was a
Okay.
70 years old patient actually of Nagpur. So he was having an uncontrolled high blood pressure and already on 3 or 4 drugs. He's already been seen by other cardiologists and physicians, but somehow he was not diagnosed with or he was advised for a renal Doppler. So anyhow, generally in any hypertensive patient, it's always advisable to do a coronary as well as for a renal angiogram.
Immunology.
Fortunately for him, he came to me and we did a renal angiogram, which was having a tight stenosis. As you can see in the treatment marker,
Yes,
it was
yes,
almost 95% blockage. So
yes.
once I did stenting to it, and you'll not believe, from 5 drugs, he's right now only on a single drug.
Great.
Great.
Yes.
And he's still following with me. I think 1 week back only he came. So he's only on one calcium channel blocker. That's it.
Yeah. So that is how I think, yeah, that's a very interesting to understand about it. And yeah, we have just, we are nearing to the end of the presentation, maybe 2 slides away again. Yes, over to you, Lavanya.
Yeah, require lifelong medication.
Sir, as you rightly,
Please tell me.
Yes.
yes. Yeah, that was my question, sir. Yeah. Sir, as many of the vital organs like heart, kidneys, brain, and all. So, do the patients need lifetime medications?
Yes, madam.
And if they take beyond lifetime medication, is there any other side effects on the patient who is
Uh,
going for
see,
medication?
I think if you don't control your blood pressure, you are going to have target vital organs that are going to be damaged, like kidneys,
Yes,
almost 50% will be damaged, and
yes,
heart, and also brain and other vessels. So it is always advisable to have your blood pressure below 130/80.
yes. Thank you, sir.
So this is the end of the slide. Yes, Nilima, I think this is a very important slide in terms of preventing this condition. Yes. Over to you, Nilima.
Yes, sir. Sir, I would like to know, sir, other than this, how can a patient can they control the BP, sir?
So what
Resistant
are the
hypertension.
lifestyle measures you like to tell us to endorse this condition, sir? Yes.
Oh, nice. So generally, lifestyle measure, as we all know, everyone knows, sodium restriction, weight loss, increase physical activity, smoking cessation, and reduce alcohol consumption. We advise for all the patient, but I don't think anyone follows that to death. And also, periodic screening is one thing that you should check almost every 1 month, 2 months, 6 months, 1 year, whatever the purpose, we have to be specific. And as I said, I don't think much of the people follow strict adherence to follow medications.
Sir, I would like
So
to add one more thing,
yes,
sir, here.
Yeah.
Is the patient stubborn? I mean, if the patient is stubborn in ceasing the smoking or the alcoholism, whatever the patient is,
Uh-huh.
how can we, ask the patient in any other way? Is there any other ways?
that is a tough question. I think yes.
I think that
Yes.
Shanti madam can help us how to
I think
guide the
the
patient
moment
when they are getting
the
from
moment
ICQ
patient
or
visits, yeah, the
AMC.
moment patient visits Dr. Kashyap and the moment the potential risks are told to the patient, I think patient maybe not drastically,
Yes.
gradually they may cease their alcohol habits and smoking.
I also want to add that nursing also, when we discharge the patient, they are more attached to the nurses before
Yes,
going.
yes, yes,
So even you people can help. Ki, please don't start smoking again, alcohol again. So I think fortunately in Yashoda, we have a very good team where these people guide.
yes. I think yes, all the nurses, we should always hold an open communication in terms of literating the patient, the do's and don'ts and potential benefits
Yes.
and potential side effects as well. So that was very, wonderful presentation, and that was very wonderful, valid discussions we all had gone through. And I urge and request all the viewers to refer www.yashodahospitals.com for more health updates, academics, and also watch patient testimonials for evidence-based learning. So we end the session, and now I think speakers, do you have any queries? You can still, the forum is open. Otherwise, we end. Yes, Lavanya. Yes, Alina and Nilima.
No, ma'am, it was a great opportunity here. I would just like to thank Dr. Kashyap, sir, who has given beautiful insights which enhanced my knowledge and cleared all of my doubts which I had in my mind. So I thank sir for his patient listening and answering to my questions. And I would like even Shanti ma'am too, who has
Thank you.
given me this opportunity and guiding me through all this session, ma'am. Thank you, all the panel
Yes.
members and even the participants for your patient
Thank,
listening. Thank you,
Thank
ma'am.
you.
Over to
Thank
you,
you
thank you.
all.
ma'am.
Please
Thank you.
share. Yeah, please share. Thank you, Dr. Kashyap. And please share this link for more learning and for more share and views. Yes, so that we know this
Yes.
condition exists and what are the potential intervention is taking place in tertiary care center like Yashoda Hospitals with the able expertise of another Dr. Kashyap. Thank you.
Thank you. Thank you. Bye.
Thank you, ma'am.
Take
Thank you,
care
sir.
all.
Thank you.
Thank you.